All right, welcome back, everyone, to another weekly neurology deep dive. You know how this works. We take a recent paper and pull out the need-to-know info to help you in your practice. And today we're looking at the diagnostic process for suspected idiopathic intracranial hypertension. But before we get going, I do need to remind everyone that this is just for educational purposes. We don't have any commercial interest here. And we're only giving a summary, so you'll definitely want to go and read the whole paper yourself. In this deep dive, we're going to really focus in on that data. So things like numbers, percentages, recommendations, all that good stuff that's going to help you out in the clinic day to day. Of course, we're going to keep it under 15 minutes, just the practical points.
Today's paper is a retrospective observational cohort study. It's titled Diagnostic Process, Misdiagnosis, and Bias in Suspected Idiopathic Intracranial Hypertension, a retrospective observational cohort study. It was just published in BMJ Neurology Open this month, March 2025.
Okay, so this study was all about referrals to the Danish Headache Center, the DHC, for patients they thought might have new onset IIH. That was between January 2020 and September 2022. The authors wanted to figure out how IIH is being diagnosed these days and see if the national guideline that they have over there is making any difference.
They looked at 96 patients who were referred for suspected new onset IIH. Turns out only 27 of them actually had IIH, so that's 28% of the referrals.
Right, so that means in a big chunk, 69 cases or 72% IIH was ruled out. And what were they ending up with?
Mostly headache disorders, 70% of them, and then pseudobapapilledema was the next biggest group at 12%.
Interesting. Okay, now when it comes to actually diagnosing IIH, this study found that optic disc edema, ODE, was the most important thing to look for.
Yeah. 25 out of the 27 patients with IIH, that's 93%, had ODE.
But here's something really important. The study found that none of these cases of ODE were found by neurologists in the first place. It was actually picked up by ophthalmologists in 16 cases and opticians in 9. So that really makes you think about who's seeing these patients initially, right?
Absolutely. So if you're looking at the numbers, the positive predictive value of ODE for true IIH was 0.74. And to compare, the positive predictive value for neuroimaging that made them think about raised intracranial pressure was just 0.03.
Wow, that is a huge difference.
It is. And the positive predictive value for the classic picture, young obese woman, headaches, visual problems, pulsatile tinnitus, that was only 0.04.
So what you're saying is, even if you get an MRI report that kind of hints at IIH,
Yeah.
it's really not as useful as a proper eye exam. You've got to get that ophthalmology consult before you go too far down the IIH path.
Right. Having those neuroimaging findings that made them think of raised ICP or just seeing that classic presentation in the clinic, those things rarely meant the patient actually had IIH. There was only one case for each of those scenarios where that was true.
But, and this is where things can get tricky, those same things often led doctors to suspect IIH, even when it wasn't the right diagnosis. Like they see those findings, they get fixated on IIH, even if other things don't quite add up.
Anchoring bias. Right.
Exactly. The study actually found that in those 69 patients without IIH, 39% of them got investigated because they fit that typical clinical picture.
Mm.
And 45% were flagged for more tests because of what their neuroimaging showed.
And a lot of that imaging was partial empty cella, 27 patients, or distended optic nerve sheaths, that was 17 patients.
Right. And here's another point that really highlights how important the ODE is. There were 8 patients without IIH who had 3 or 4 of those neuroimaging signs that usually point to high ICP, but none of them had optic disc edema.
It's a really good point. So the imaging can sometimes be misleading. You can't just go by that.
Now let's talk about misdiagnosis. Unfortunately, it happened. In this study, it was 11% of the referrals.
11 patients total. And of those, 9 were false positives for IIH. They even got started on treatment to lower their ICP, even though an ophthalmologist had already ruled out optic disc edema.
So those patients were put on medication they didn't need.
Yeah. And the interesting thing is, 7 of those 9 patients had a high opening pressure on lumbar puncture, 25 centimeters of CSF or higher, but they were missing other key things you need for an IIH diagnosis.
So it just goes to show you can't hang your hat on one finding alone, even if it seems really convincing. You have to consider the whole picture.
Definitely. You've got to look at everything. And on the flip side, the study also found some potential false negatives where they might have missed IIH. There were 2 patients who had high opening pressure and 4 of those neuroimaging signs of raised ICP, but they didn't have ODE. The DHC ended up saying they had a primary headache disorder. But it does make you wonder if maybe they had IIH without papilledema.
That's IIH-WEPI-OP, right?
Yeah.
Okay, now another thing they looked at in this study was the whole process of diagnosing these patients. And they found that when IIH was actually confirmed, the workup was more thorough and it all happened faster.
Yeah. And those differences were statistically significant. Patients with confirmed IIH had usually seen 3 different specialists before getting to the DHC, while those without IIH had only seen 2.
And as far as specific tests go, the patients with confirmed IIH had way more cerebral venography. It was 81% compared to 20%, and lumbar puncture 85% versus 29%.
And a much higher rate of fundus examination, too, 93% versus 45%. And more visual field testing, 59% compared to 25%. All those differences were statistically significant.
And they found that the average opening pressure was also significantly higher in the IIH group, 36.4 centimeter PSF compared to 26.4 in the non-IIH group.
Makes sense, right?
Yeah. So while this study was going on, Denmark actually rolled out a national guideline for managing IIH. And they found that this guideline did help reduce mismanagement of the whole diagnostic process, thankfully. It went from 44% down to 20%. It's a pretty big improvement.
Definitely. But when they looked at how accurate the diagnoses were overall, it wasn't so clear. They did see a drop from 38% to 21%, but that wasn't statistically significant. And the rate of misdiagnosis actually went up a bit from 8% to 14%. But again, that wasn't statistically significant either.
It's interesting that even with a guideline in place, it doesn't completely solve the problem.
Right. And there's another interesting point. They started getting more referrals every month after the guideline came out. Went from an average of 2.3 patients to 3.5 patients.
So maybe the guideline raised awareness and more patients were getting sent their way.
Could be. And one last thing. They looked at how quickly patients were getting an eye exam. The median time to that first ophthalmic assessment was the same before and after the guideline, about 36 days. That's a long time to wait when you're concerned about vision loss.
Absolutely. Especially considering that they found 33% of patients didn't even have an eye exam before they were referred to the DHC. That's a lot of patients who could be waiting weeks for that crucial first look.
And in those cases, that first fundus exam took a median of 36 days, but it could be anywhere from 16 to 67 days. That's a big range. And for some patients, that delay could really make a difference.
So what are the authors saying we should do with all of this information?
Well, they're really pushing for us to prioritize fundus examination in any patient we think might have IIH. They say that eye exams should be the driving force behind our whole diagnostic plan, not only to avoid unnecessary tests, but also, and probably most importantly, to protect the patient's vision.
And they're suggesting that maybe we should be using tools like fundus photography more often, even in primary care settings. That way, we can maybe catch those cases of ODE sooner and not have to wait for a specialist appointment.
Exactly. They're saying it could streamline the whole process and maybe even take some of the pressure off those tertiary care centers.
Makes sense. And they're also calling for better diagnostic biomarkers for IIH, something more objective that we can use to help us make the right diagnosis. Because right now we're relying a lot on our clinical judgment, which, as we've seen, can sometimes lead us astray.
So to sum up all this for our listeners, if you suspect IIH, the most important thing is to get that fundus examination done as quickly as possible. Don't get distracted by MRI findings or just the typical presentation. Those things can be misleading.
Absolutely.
Hmm.
The study showed us that those things aren't as reliable as we might think. They can even make us biased towards an IIH diagnosis.
Right. And even though guidelines can help, there are still gaps in how we diagnose IIH. We need to make sure patients are getting that eye exam quickly.
So for those listening, think about this. What if you started doing fundus photography routinely in your clinic for any patient who comes in with symptoms that might point to IIH? How would that change how you diagnose these patients? And how would it affect their outcomes, especially when it comes to their vision? I think it's something worth thinking about. It can make a real difference.